everyone. My name is Allie Bailey, and I'm introducing today the Better You podcast. And today we are going to be talking about mental health utilization. Joined with me today is Dr. Patricia Parker, as well as Ravi, and we're going to be discussing this topic with you all today. And we would love to be able to hear your feedback as we go through our conversation by subscribing to us, but also sharing your thoughts in the comments section. We're going to be having just a great panel conversation. So, we're going to be going over a lot of different topics based on mental health utilization. And I figured I would pass the baton over to Dr. Parker, who has a lot of insight on this topic. How are you today, Dr. Parker?
Oh, I'm fine. I'm fine. So happy to join with everyone today to discuss the utilization of mental health. I've been in the field for quite a long time, probably close to 40 years or more of service. I am a native of Franklin, Virginia, and currently reside in the area of Homestead, Florida, Sunshine State. And actually, there's a long history to how I came into the mental health area. Actually, I started out as a teacher. I was teaching adults that were going back to school to become clerk typist, nurse assistant, or data entry. And what I found is that in working with these adult populations, that they had some problems focusing on their school work and class tasks due to mental health issues that they were having in their lives and in their homes. I had a student that came that had been with some bruises, had been physically abused by her boyfriend because he was upset because she was going back to school to better herself and he didn't like that.
Mhm.
So that drove me into the interest of family therapy and also the clinical aspect of mental health. So I returned to school to become a family therapist at the Medical College of Pennsylvania, Hahnemann University. And I did a lot of family work. I went to a lot of homes and visited with the families. I also was a case manager and also a social worker where I did home visits and worked with life skills with some of the families in their homes. And after I completed that journey, I became more interested in the clinical aspect of medication for treatment of the families. And I returned to school to obtain my PhD in clinical psychology at Walden University, which brings me where I am today. I do family therapy, individual therapy, couple therapy, also group, mental health group, substance abuse treatment. And also, I developed a group on how to use therapy, which brings us back to our topic today of because for some people, therapy is a very new aspect. Some people they may go to church, they talk to the pastor, they may talk to the priest. Some
Mhm.
people just keep it within themselves and speak within the family. So it's a very new concept for some people. In this group, I developed on how to use therapy. I would talk to the patients about how they could feel comfortable just talking and expressing their concerns with their therapist and how to go back and communicate with their own individual therapist so that they would feel some calmness and peace when doing this communication. Therapy, we call it developing a therapeutic bond and relationship to
Mhm.
teach them how to develop a therapeutic bond and relationship with their own individual therapist.
Okay. Okay. And I appreciate you going into great detail of your journey thus far and bringing you to where you are now. I know you mentioned that you were in quite a few different states, but you never lost your passion for working in the mental health field, but you only gained more experience. And I'm sure it touched a lot of many, many lives as well through your great work. And I always say our experience speaks for itself. And just again, from what you shared, I can sense your passion in what you do. You never work a day in your life. And I think as mental health providers and any other job that we enjoy, that's really what we strive for. And I'd love to be able to inquire a little bit more about the groups that you've ran and currently run and learn again a little bit more about your insight into what it takes of being that participant, because I know with group we're involved not just individually, but we're in a group setting. So I think that also gives a lot more accountability. But for I guess my question, and Ravi, you're more than welcome to always jump in as especially when we're speaking with one of our guests, but recognizing the signs that one might need services, right? I know sometimes that's the biggest struggle, right? Is picking up the phone or contacting on a form of getting help. In your professional opinion, what does that look like for you of somebody recognizing that they need help?
Well, some of the things that I've been able to recognize is when the person's mental health interferes with their everyday functioning. If they're working, it's hard for them to go to work. Maybe it's hard for them to get up and get out of the bed because they're feeling sad or feeling blue and they don't know why, they just are. And then you have other people who struggle with various types of anxiety. Sometimes they have panic attacks that come from nowhere. And just feeling losing hope, losing faith in day to day living are some of the signs that one is in need of mental health treatment.
Absolutely. And I think too, being anxious can also lead to feeling frustrated and feeling down on ourselves. And a lot of negative emotions can come with that. And I think it also deters one from wanting to find help. And I think too, it's hard to be able to just go on to the web and say, hey, I need help with X, Y, and Z, and feeling comfortable even sometimes facing what we may find is our crisis or a problem, right? When somebody's reached out to you, and I guess this is just a question from me as a clinician standpoint, how have they approached you of needing help? Do they come out normally and say, like, I need help, or is it more, I guess, in detail of what they're going through?
Well, they come out to me in a lot of different ways. Sometimes I might get a phone call
Mhm.
that they're in crisis, or sometimes they may just walk in the clinic. They can come in on their own sometimes in distress, expressing various mental health needs. And therapy sometimes can be a very scary, cold place for some people, walking into a crowded waiting room and there's a lot of people sitting around. A lot of people don't feel comfortable in those type of environments. And so I try to do everything I can to establish a rapport with them. How was it for you coming in? Not just come in and have a seat. How was it? Was it hot? It could have been maybe if it could have been 100 degrees out there. I don't know. It could have been raining. It could have been snowing. What moccasins are they actually walking in? I try to be in touch with who they are at the present moment to make them feel comfortable. Not that they're just another person in a waiting room waiting to be seen. And I think that is, I might even spend a whole session on that. Depending on the level of comfortability that I'm able to sense in that particular client. So I think it's important for the client to feel that they can easily approach the clinician. I don't refer to them as clients. I don't call them clients. I don't call them patients. I talk to them and ask how they're doing. And I refer to them, actually, I refer to them as folks, just regular people. Nobody wants to feel like a social security number. So I try to give that personal embrace. Very, very important thing to do. in working with the client. I try to take a very humanistic approach. And sometimes they might stop at the vending machine and get a few snacks. I say, "Oh, would you like to get a snack?" If they come in my session, sit down and have a seat, and if they want to eat a bag of chips, it's okay. Because
Yeah.
the main thing I want them to do is feel comfortable. I'm not going to say, there'll be no eating in the session. I'm going to pull out this yellow pen. I'm going to ask you a few questions. I don't operate like that. I'm just more like, how you doing? I want to make sure that you feel comfortable in your own skin. Feel free. Some clients come in and they're anxious and they might stand up,
Yes.
walk. I'm not going to say, I want you to sit in that chair over there. If they're comfortable standing, let them stand as long as they tell me the story.
Right.
That's all I
Right.
care about. I don't care if you sit and tell me. I don't care if you stand, kick your shoes off. I've had kids, parents come in and bring the children in, and the parents tired and it's hot outside, and baby kicks the shoe off or whatever. I'm gonna say, put that shoe back on the baby. Just whatever's gonna make them comfortable. That's the most important piece.
Yes. And I think, like you said, it all comes back to one's comfortability. I think we could take a little bit of time and probably go over a few different experiences that we all maybe have had that have taught us that, hey, when I go somewhere, I can share mine, but I want to pass the floor over to Ravi. I saw you had unmuted yourself, and I was going to see what you had wanted to share, but I certainly after I can definitely share a little bit about an experience I had where I went to, and it wasn't behavioral health, but it was more medical health related, and I love all physicians certainly, but this one experience really stood out to me where I didn't feel like a human. That's what it comes back to. We're not a client nor a patient, but we're a human, and we have feelings. And sometimes when those feelings aren't met, and we feel a little bit back into our shell, almost like a turtle, sometimes makes us more apprehensive to reach out for that help. But go ahead, Ravi. I didn't want to cut you off. I thought you were going to say something.
No, no worries. Dr. Parker, that was a great way of having your folks introduce to themselves, just being in a very comfortable environment, like you mentioned. I feel like not a lot of people in day to day are even able to do that. But my question was in terms of the baby step to having to take that first step of going through a clinician to get a therapy done, what is a person like? What should they do? They know they need help, right? But they're scared to pull that trigger of I'm just too anxious to make this therapy or to go to this therapy. What should they do? How that can be helpful to the viewers.
Well, you have the crisis hotline number 988. You simply just pick up the phone and dial 988 and let them know that, listen, I'm in a crisis, or I may be going into a crisis, or I just need help. Where can I get help? That's a number that they can dial. And there's various resources, and some of the churches you can reach out to have lots of resources in terms of mental health. So it's a matter of sometimes just picking up the phone and just dialing those three numbers to get the help that they need. Or there are places too you can walk in, just walk into your nearest mental health facility. Also, sometimes teachers have resources for the children that are in school, often refer them to counseling services. So there's lots of different ways to get in.
What makes sense in terms of it's basically just a notion of doing it, right? Rather than having all these different thoughts about, oh, just different some people when they get into their head all these overthinkers, it stops themselves from doing the effort or the time it would have taken them to go through mental health, but they just curl up in a ball and then stop themselves. So no, the notion of just going for it, I think makes sense. Yeah.
Yeah, it's very difficult, and I've seen a lot of people come in the clinic in that kind of state. And first thing I want to do is establish a level of comfort and a relationship with them, because that's more important than the diagnosis. First of all, the person has to feel comfortable. They have to feel like they're a person. Even during my sessions, I don't even take notes sometimes. I don't always pull out that yellow tablet and start writing because it makes the patient nervous sometimes. What is she saying about me? What diagnosis is she giving me? So it really all depends. I really am an advocate for taking a very simple humanistic approach to treatment.
I have another question. Ali and Dr. Parker, I think it's for both of you guys. So my background, mental therapy or any type of therapy is not a norm, right? It's basically frowned upon in a way. It means that you're kind of weak if you say something to your family or your friends that are from the same background. So I just wanted to see how can I utilize that towards a family, towards a family friend, to have them know that mental therapy is normal. Anyone needs it. Anyone can make use out of it.
There's a lot of stigma about mental health, mental illness. That if you have a mental illness, there's something wrong with you, and there's all kind of stigmas about having to ask for help. And so that is why I spend so much time. Generally, in the beginning, I ask them if they've ever even been in therapy before. Have they even heard of therapy? Some say yes. And if they say yes, I say, how was it? What did you like about it? What didn't you like about it? Either way, those two questions are significant to me because it gives me an idea of where I need to go with this client. If this client has never been in therapy before, they've been told, then I have to reflect on the feelings of that client right where they are. I have to meet them right where they are. You've never been in therapy. This is something different. And I tell them it's just a matter of talking and expressing their feelings and just saying how they feel. This is not a classroom. There's no right or wrong answer in here. You're not going to get a bad grade. No, you don't have, you don't have to raise your hand. You can just talk. I say that to a lot of the children too when they come in. I tell them I'm more or less a helper. I'm your helper. If there's something going on and somebody bothers you or you have a problem, I'm here. I'm here to help. And speaking on the little children, a lot of times we have what we call play therapy, where you take out the little blocks and the little dolls, the choo-choo train.
Yes.
And naturally, the kids that's 4, I have children as young as 4 years old. The first thing they want to do is play because that's their world, the play therapy. I make a deal. I say, look, I'm going to make a deal with you. I tell you what, I'm your helper. I'm here to help you. And we're here to talk about whatever problem, whatever bothers you. I make you a deal. For the first half of the session, if you talk to me about your problem, the second half of the problem, I'll let you play. Then we play. But you got to do some work first.
That's a good deal. I think if I was a kiddo and I was in therapy, I would take that deal any day. It's great. And to piggyback off what you had said, yes, sometimes there is unfortunately that stigma where it is frowned upon for reaching out for help. And, that's why as providers, we're up to date on all of the best information that we can provide regarding the benefits of mental health. So I know as a clinician myself, I've had some folks bring family members to session or friends, but again, that's up to the client to bring them in and without getting into their concern, unless they want to discuss it amongst themselves in the session, have addressed like, this is why I come. I feel safe in this room. And going back a little bit too to the humanistic approach, we all are human at the end of the day. We have feelings, we have emotions, and we're people. And it's very difficult to reach out and ask for help. I know, and I'll touch on it very briefly, but I remember I went into a medical office once, and it does happen quite a bit. Allie's my short name. I say Alexandria is my legal name, but whenever I go to the doctor, Alexandria is the name that they have on my identification. So they always seem to call me Alex or Alexandra. And sometimes this one experience I'd had, they kept repeatedly calling me like Allison and every other name except Alexandria or Allie. And I just felt less of a human when I was there. And I was like, going forward, I will always ensure that the clients that I work with will feel heard, even if it's just their name, that makes or their preferred name that makes them feel most comfortable. Have either of you ever experienced something, and it's totally okay if you don't want to share, something that changed your approach in the work that you've done, maybe personally, professionally, that you'd like to talk about today in our podcast?
Well, I think what challenged me, what affected me was when I was out there teaching,
Hmm.
teaching experience. When I saw the woman come to the classroom with bruises all over her, that she had gotten beat up right before she could get into the classroom, and she sat down and she cried and she cried. That deeply impacted me, and I had to pull her aside and I said, "What's going on? What's happening?"
Yeah.
And then she began to tell me the story about the abusive boyfriend that she had that didn't want to see her go back to school to make anything out of herself. So that's what made me really get into family therapy. That things are going on in the home front. You
Yeah.
don't know what is going on in their eco-structural environment. They're deeply impacted. That has to do with a lot of how they look at the world. And my dissertation that I wrote was on the patient's concept of the lack of the counselor's lack of cultural awareness and the impact that it has on the dropout rate in treatment among African American and Hispanic patients is what I did my dissertation on. And that applies to everybody across the board. It's very important to understand the cultural aspect of a person, including their eco-structural environment. Not just when I say culture, I'm not just talking about race. I'm talking about a way of life and how they live and
Hmm.
what has impacted them in their individual environments.
Exactly. And like you said, it kind of goes back to what's happening behind closed doors. As professionals, we do see folks that come into our office or through our telehealth doors, but we don't always get to observe their environments at home. Ravi, was there anything you wanted to add to that?
No, in terms of the culture difference, I have that a lot with my family. I was not born here to begin with, so coming to America, being grateful for it to begin with, there was just a lot of different perspectives that I saw when I was in middle school or where I'm at right now. Getting to know the culture, I think it makes me more stable in a way, and then makes me more calmer.
Yeah.
This is how things are done here. Back in India, there are things different. Every day is a hustle, or there's a calm moment. But over here, you have your normal work routine from Monday to Friday, and then you have your weekends to yourself, where you meet family. But in other cases, where in India, it's such a happening place where you can just go to a family member or your neighbor. So everything is reachable to you.
Abs- Absolutely.
Yeah.
Yeah.
Uh,
Absolutely.
yeah.
That's exactly true and how things are done. And then there's so many things that constitute family. That's another thing that I found out in working out in the field is that family doesn't always have to constitute a blood relationship or kinship. It can be a neighbor. It might be a friend that you've been friends with for 25 years. You've been friends with somebody for 25 years, you're family.
Yeah.
That's a long time to be friends with somebody.
Yeah.
And just it depends on who you establish that comfort level with. It can be a lot. Family comes in a lot of different contexts. Just doesn't always have to be blood related.
Mhm.
So I found that to be very fascinating because when I was out doing the social work and talking to people in the community, I would talk to people in the community and talk to the neighbors. And I'm looking for so and so. Oh, you can ask John right down the street. He probably can tell you a little bit more with it because we're family around here. We're family. We're a community around here. We all look out for each other. And that's not something to dismiss. You'd be surprised how much you will be able to find out from those folks. And same thing in a school setting and in some of the institutions. You have the receptionists, the people at the front desk. You have the maintenance people. You'd be surprised how much a client might tell that person. That person might be able to tell you a lot about the patient because they deal with them on a daily, day-to-day basis. I found that out when I was working because I also worked in a residential facility too, where we were in the cottages. I stayed in cottages and they had cooks in the cottage, and those cooks that cooked for the children that were in foster care had a lot of insight. They'd say, "Oh, Dr. Parker, so and so had a visit this weekend. I think you might need to know this information. Let me just tell you a little bit about what happened because I know you're not here on the weekends. So don't
Yeah.
dismiss those people because they have a lot of information. Some of them will tell them, some of the patients will tell those folks more than they tell the therapist. It's amazing.
And to gain all of that insight from different folks. And I also use the term folks because, like I said, it all goes back to being a human, feeling humanized when we're receiving care. And even myself personally, I'm the older sibling of two, and I never had an older brother or sister. So I actually have friends who I've known for many, many years that I will call them my older sister or my brother. And that's just what they've become to me. And I know I don't have many cousins that I'm close with, and some friends are more cousin, aunt, uncle, niece to me. So I know whenever I have something going on, I know who I can lean on. And it's great to hear though that there are communities out there where a neighbor is more of that friend. And I think that kind of goes into our next topic that I want to address with mental health utilization of helping others find help. I know you mentioned different crisis lines like 988, which is a 24-hour resource that anyone can utilize through chat, text, or phone. But I think someone having that trust in you is important because then they feel comfortable looking through what those options are to ultimately determine what they're looking for. I think sometimes if someone walks through our doors and says I'm in a crisis, well, we can't determine what that crisis is. That's up to them. But like you said, meeting the person where they are, whatever in whatever moment that looks like, whether it's sadness, extreme anxiety. Sometimes people reach out that are happy, right? And they're like, before this happiness goes away, I trust you enough to help me find what I need. So something that I'm curious about is how you help to determine what someone needs long term, because I know in crisis services, you're meeting the person where they are and helping to stabilize them and de-escalate them. But how do you manage for that long term support?
Well, long-term support, generally, I'm looking at whether or not the person is going to be a threat to themselves or somebody in the community.
Yeah.
We have a duty. We have a duty to warn. Somebody like that could be somebody that needs just a little more than just outpatient counseling. If they tell you, I've had people that tell me that they had a plan of how they were going to kill themselves. And I say, do you have access to it? Oh, well, I got a bottle of pills on my dresser. I can just take this. Or, so I've had to hospitalize people for many times and many years for some of those reasons. Or I'm going to jump in front of a moving train. There's my window I can jump out. And so I want to know if you have a plan. You got a plan in place, then you got to get these people. This is somebody that's going to need inpatient type treatment as opposed to just a short term. It's going to be a need for further evaluation.
No, exactly. And I appreciate you going into detail about the Columbia risk assessment. And I know as clinicians, we are mandated to ask those. So the Columbia scale, for those of you tuning in, those are our, I say, mandated or required questions for us to go over with a client who's expressing suicidal and or homicidal ideation, which is extremely, extremely important, especially for looking for what next level of care one may need. Sometimes, yes, depending on the answers to those risk assessment questions, one may need more sooner, immediate help versus rolling into that longer term care. And there are many different types of treatment. I know myself, prior to relocating down to Florida, I had some experience working for a behavioral health agency. So it was not just technically providing therapy, but I was in the field with 9 to 10 families that were assigned to me over a few month course. I would go to the homes in the schools, and I was able to see one's life, not
Yes,
just in the office or through telehealth, which was amazing. And I think services like that definitely can be that bridge, as you were mentioning, between going into inpatient or being an outpatient client. You help people from the comforts of their community, maybe even just in the office, or a mixture of both at times. But something that I always like to ask professionals like yourself who have great experience, as you mentioned, being in the field, what has been one of your most favorite and best types of treatment that you feel you've provided? And when I say best, I mean one that just really resonates with you. I know you mentioned family therapy and also the work in the field, but is there one experience that just resonates with you the most?
well, I think it was back in the 90s when I was working in a residential facility with the parent as a residential social worker. The child was in placement because the mother had a substance abuse problem and there were housing issues. I was able to get the mother into a shelter where she could secure housing and also substance abuse treatment.
Hmm.
Through the substance abuse treatment, upon the completion of the substance abuse treatment, she was able to go back to work. They had job training where they taught them job skills. All of this was at the shelter. And to see her to be able to become sober and also obtain employment. And later on, with the case management services that was available at the shelter, she was also able to secure housing and
Wow.
suitable housing. And then once that happened, she was able to actually have her child return home to her.
Wow. Wow.
And I
That's
think I was more touched by that particular situation, those steps.
and I think that can be more rewarding than any, and I know we all work for, I say, financial gain, right? But morally it just feels amazing to be able to say I made a difference in one's life, and being a provider, being a professional in the behavioral services, and sometimes to also medical field, right? We are able to provide that great level of care, that compassion. And I know one visit isn't always a fix, right? But even just coming in for one visit allows one to have hope. And I know you'd mentioned earlier on, and I'd really like to take some time to dive into the group that you'd mentioned of teaching folks like what it's like to be in therapy, what's expected. I know when I think of DBT or dialectical behavioral therapy groups where you build a life worth living, it's 8 to 10 weeks sometimes for a group, and then you switch with new individuals coming in. Can you explain to us the structure of what your group may look like, and how you would go through that group with your clients?
Well, basically, I start very much at the root. I believe in starting from the ground up. First of all, I teach them what a group is supposed to be like, how to be a group, first of all. Let them know that the purpose of them coming together as a group is for them to be able to share and be some type of support for each other. If you come to group and you notice that you didn't see Joe this week, but you saw Joe last week, check and find out if he's okay. I try to encourage them to establish a buddy system, a buddy with their peers and get to know their peers, to talk to their peers, socialize with their peers, check in with the peers and see how they're doing. That establishes a form of cohesion among the group. It's more to a group than just having a bunch of people in a room sitting around in a circle. That doesn't make them a group.
Yeah.
They need to feel connected to one another, and they need to connect with one or the other, with each other. And that's the very first thing that I like to establish, because I know that everybody doesn't really know how to do it to be a group. That's just the most important thing. And the same thing with family therapy. When I'm doing family therapy, I'm looking around the room, I'm observing when they come in, where do they sit?
Mhm.
Who do they sit next to in the family? And I'm asking, if I'm doing individual work with them, and I'm asking them and they have a hard time opening up, let's say, talking or whatever. I'm going to go and I'm going to explore the family, and I'm going to say, who are you close to in your family? You talk to anybody in your family? It's not talking to me, so who you talk to? It might be somebody in that family who you're close to. Sometimes I've had to have a family member to come in. I
Yeah.
may say, will you feel more comfortable if you brought in, if Aunt Carrie or Aunt Mary came to? Then I find out the Mary comes to session or the Aunt Carrie comes to session, and they start talking their head off
Mhm.
because their aunt is right there with them and they feel comfortable. That's some of the things that I try to explore and see where they are in terms of their level of comfort. And I also do couples therapy. I work with the couples and I talk to them about, sometimes they have a lot. Oh, we're not as close as we used to be. We're not, the intimacy is out of the window, and we don't have the same, there's not a lot of affection here. And I say to them, what brought you together as a couple in the first place? What was it about Sally that you liked? And they talk about what it was, what they do. Because a lot of times, what they do is, especially if children are involved, they get used to going to work, paying the bills, and taking care of the kids. Going to work, taking care of the kids, and paying the bills. So much of that goes on that they lose the
Right.
couple time that they used to have together. And that has an impact on the intimacy that occurs in the relationship, that you're no longer a couple, but it can also seem like it's a bunch of roommates living in a house together.
Yeah.
It happens. I try to closely examine and take a look at that, and sometimes I give them a homework assignment, where they can go home and interview each other all over again. What would you like to see happen in this marriage? What is it that you like? What is it that you don't like? We talk about compromise.
Mhm.
Living with other people takes a great deal of compromise, learning to compromise with one another. So those are some of the things that I work on, and I found it to be very helpful to people who come to me for those particular type of modalities. And sometimes I've even had to have, maybe they can't get the family to come in for family therapy. Oh, Alice, no, she won't come in. I can't get anybody to come in, but they still need that family therapy because they're presenting to me everything that's related to some family situation. So I use the empty chair technique. I say, what if Aunt Alice was sitting in that chair right there? What would
Yeah.
she say to you? What do you think she would say if she was here? No, she's not here now, but what will you tell me? What would she say? She would probably tell me, oh, to get a grip, and I need to get up and go get a job, or I need to do this or that. And then
Yeah.
from there, I take it from there, because sometimes I have to do that if they can't get the person to come in and support them.
Right.
That's another technique, so you won't be totally lost even if the family member doesn't show up. We'll talk about what would happen if the family person was there and
Yeah.
continue to go on and explore and to make them feel a level of comfort.
Absolutely. And there's a lot of different therapy techniques. And I think that's what's great about having a lot of experience and knowing which avenues to go, right? Because we never want it to come off that we're unsure of what to do next, right? Like you've mentioned quite a few times in our podcast so far that we are the helper. And if we don't seem that we know what steps to take next, one may feel that lack of support, that lack of help. And as Ravi said, crawl into their shell essentially, or crawl back into a ball and feel like really there isn't any help for me. So empty chair technique, it's almost like we're gaining that perspective from what that person may hypothetically say, because the people coming in for help or for treatment, they know the people in their lives certainly much greater than us, and they can paint a better picture and provide us with that picture and that canvas, so we know this is maybe how one responds to what's said to them, or this is the behavior that they witness of why there's active issues or concerns with a relationship or a friendship. But we've said too, with everyone's crises or crisis that's actively happening, it's not up to us to determine what that is at the time, but for us to guide our folks on that journey of a walk to a great overall mental health mindset. And Ravi, I saw you had unmuted. Did you want to add something?
No, I just wanted to bring up a little bit of a controversy topic with news and mental health. Seems there's been a lot of suicides in general throughout the world, I guess, where the news outlet doesn't mention anything of it. I just wanted to see, like, why is that? And we do our best at Lemco Wellness to pursue the fact of, please reach out to us if you need anything, right? As a helper. Doesn't news as a community, right? They give out news about literally every single thing that's happening around the world, right?
Yeah.
Um, if a turtle has gone past age 100, they'll mention that in war, so many different things. But there was a case in Chicago that recently happened. This is a well-known place where I like to go, and I like to show people when they're in the town, because it's a beautiful sight from this one hotel where recently 5 days ago a man jumped out of that building. None of that was mentioned in the news outlet. It was only posted via social media, and that's the only way that I found out. So just wanted to see how why is news not a probable cause of reaching out to people? Hey, please, if you need help, dial this. Have go through a crisis center, such as.
Well, sometimes when those things, sometimes they sweep things under the carpet too. Hush, hush. They don't want the community to be aware of that something like that is happening. You have in some, particularly some of the more elite communities, I think you have more of that where it's swept under the carpet, where we call it family secrets. It's just not talked about. They just don't talk about it. The thing about suicide, the other aspect of that, the really true, it's scary, but the really true suicidal person is unpredictable. So if you talk to someone and they start saying, "Oh, I'm gonna kill myself," I might do, please take that person seriously. Say, "Oh, he just crying wolf. He just saying like that," but you don't know how far that person's going to go to get that information. And the real, true suicidal person, if somebody's really, really, the only thing you can really do is try to make sure that you're aware and that you put the correct services in place, support services, support systems, contacting the police department, social service, mental health, therapists, try to contact and have all that in place. But when somebody really, really, really got their mind made up that they're going to harm themselves, sometimes you can't stop it. And because you may not know, there may not be any signs. They may not tell you.
Right.
Now
Yeah.
that's a scary reality. But that was one of the things that we were taught in school. So you can't blame yourself. Why? I'm talking as a clinician, talking to the clinicians now. I couldn't stop that person from killing themselves or taking their life or whatever. someone really, really wants to do that, and they don't give any signs or any warning, there's nothing you can do to stop. But the only thing you can do, if you are aware and have some kind of inclination, is to make sure you put the right support services in place.
Absolutely. And to speak on that as well, I don't have much else to add other than what you had said already, Dr. Parker, regarding the news and the streaming of different, unfortunately, the places where these have been experienced. But as a clinician, but also at the end of the day, being human, unfortunately, we never know the next moves of another person. So, yes, taking anyone's word, I say seriously, right? Because, like you said, sometimes people will say, oh, that person's crying wolf, or it's been a recurring pattern. I know when I was already on my path to becoming a clinician, a few years back, when deciding what I was going to go for, if I was going to go back to graduate school, I experienced the death by suicide of a great friend of mine of almost 10 years. Very tragic and unexpected. Did not expect it from this person. No warning signs whatsoever. It just one day was told to me, and going to the service and seeing everyone, no one could believe it. And that was when I'd taken the path of going in back to school. I say I just graduated a couple months prior, but returning very, very quickly during the height of COVID to school, and almost using schooling to heal myself from that experience, but learn what next steps I could take as the helper in the helping professions field to try to ensure the best for humans and folks coming in for those services. And through even my work, I've talked to many, many people who have considered it, and quickly did not consider ending their life by suicide anymore because they learned how to take care of themselves. And that's why I was just so excited to jump on with both of you today. And I know we're coming towards the end here shortly, but to be able to talk about this topic of mental health utilization, I know when we read the words on a paper, it's to maybe others just words, but to us in the field, and also those watching, it's important. There's just so many different avenues that you can take and to get help, and teach others how to have help. But something I know we've all been kind of talking about is forming that relationship. And I think it does start with when somebody walks in the room of, how was it getting here today? How are you feeling since last week? Because I think quite a bit of time can pass when we leave our home to the time we arrive at a clinic or a mental health center, right? I know too. If I got in my car right now and drove down to even the gym, a lot can happen between now and then of how I feel. So that's why it's just super, super important to build that connection, and also that consistency, like you mentioned, ensuring the best for when somebody comes in. I know too, and maybe you can speak to this as well as the clinician. I know keeping our folks consistent and coming back week to week, of course, unless they're sick or something, but how, as a clinician, do you feel that you keep your consistency as well?
Well, I check in. I try to check in with them and do very close follow up with them to make sure. And if someone is more critical than another, I try to move them up high in the week. As opposed to seeing them on a Friday, I might see them on a Monday because I don't want the whole week to go by and a person I know that they're in a crisis like state because things happen and change from moment to moment. But I try to, as I say, build that rapport when they come in. How's everything since we met last week? It's good to see you. I tried to reach out to you, but I wasn't able to reach you. Is everything okay? Just that constant checking in with them and checking back and just doing very close follow up because the clients can feel that, the patient can feel that, whether or not you're really in tune to them and what's going on in their life and really what's happening. So I would say doing very close follow up and establishing that therapeutic rapport, the bond, the relationship. Relationship plays a key factor in the treatment process. You got to have a relationship with your patients. And I tell the teachers that too. The teachers, a lot of times they're complaining and they call. about how Johnny is not focused or he's not paying attention and he doesn't. Have you established a relationship with Johnny? Ask him how's day going. How's he feeling? He had breakfast this morning. What's going? You got to almost be like a buddy with those kids. Buddy or a helper, but the kids got to feel connected.
Right.
They got to feel connected, even with the teacher. And I tell the parents. The parents are telling me, "Oh, I got a call from school, and he's acting up, and he's not following directions. He's not following the rules, and he's not." I said, "Go up there and find out for yourself what's going on. There's always two sides to every story. You don't know what that kid's going through in the school when he goes in there. There's a lot of bullying thing that's going on, bullying going on in the school settings. A lot of times the kids are not going to tell you because they're afraid to tell anyone. So I tell the parents in the family therapy sessions, I get the kids tell me, my mom doesn't listen to anything I say. I'm the adult. I'm the grown one here. I tell the parents I have to put the parents in a session by themselves and I say, listen, listen, listen. You have got to allow that child to have a voice. You
Hmm.
don't have to agree with them, but you at least have to listen.
Right.
Listen to what they're telling you before you go completely critical on that child. Find out what happened. Go up to that school, meet with the teacher, have a parent teacher meeting, and
Right.
find out what's going on for yourself than just taking what is said to you over the telephone. Because some of the teachers, they don't have a lot of those, I hate to say it, but some of them don't have a lot of good psychology skills as far as just trying to understand their goal is to come in there and complete a certain amount of classwork within a period of time without really looking at that child and seeing what's really going on with their child.
Yeah.
So those are some of the things that I see a greater need for.
Yeah, no, absolutely. And I think you're very consistent with following up with parents and or sometimes, right, as professionals, we might sign releases of information to be able to speak to one's med provider, to their teacher, to just be active overall in other parts of one's world. So that way we're in the know. We know where we can go with our therapeutic approach. And yes, I agree that also keeping one's accountability is very important. I say kind of doing the work, right? Because while we are the helper and the guide, we can only meet the person where they are. And sometimes clients are ready to take 5 steps forward, but then maybe that next session they just want to stay where they are, and that's totally fine as long as we're providing that comfort of self. And something that I've read is that therapy is a process of self. And I know that can be interpreted in many different ways. And at least for me, I think, look, if I were to have an invisible mirror and I look at myself, how far have I come from yesterday to today? And how far do I want to push myself to be to tomorrow? Again, not push myself, but where do I see myself tomorrow, right? And with thinking of that, hearing that therapy is a process of self, what do you both take away from that?
Self-care. Self-care is very crucial.
Yes.
Let's take care of yourself as a clinician. It's very, very important. And if you have any type of underlying issues, you need to take care of them. The best therapist will go see another therapist.
Yes.
If
Yeah.
you're someone, I'll give you a perfect example. If you're someone that suffered some type of physical trauma or some type of abuse at some point in your life, and you didn't get that taken care of, you must go into treatment. Let's go. Because what's going to happen if you get a client, you get a patient in there, and you haven't worked through your issues? How are you going to help the client?
Right.
You're going to get stuck.
Yeah.
There's going to be a roadblock in the treatment process. So that self-care and self-help is a very, very integral part of the treatment process as well, keeping yourself aware and up to date about the newest diagnosis that's in the DSM-5. TR, the latest forms of treatment, and keeping yourself aware and abreast of what's happening.
No, absolutely. And like you said, keeping yourself informed. I think in the mental health field, it's ever changing. So every day there's just something new. There's a new update for us, especially with assessing folks when they're coming in and out of our care. There's new techniques that we can use with one. I always say with clients, right? Like there's many, many different things of research, and one size does not always fit all. There's many different ideas and perspectives. And if one doesn't resonate well with you, well, there's many others that we can explore together. That as I observe and see best, we can go down that route. But Ravi, you wanted to add on as well?
No, just wanted to say thank you to both of you, and then I didn't get the chance to say thank you to Dr. Asher last podcast as well. It's just the experience you guys both had from what you had is now where you are right now, helping all these other people. So thank you for what you do. It's not an easy task that you both deal with, but keeping that composure of just being yourself with a folk, with another person that you do. I learn from you guys, like the way you guys talk, the way you guys handle things. I try to apply it to my day-to-day life or someone who I talk to. So no, thank you.
Absolutely, you're welcome. And I think even though we all have went through some sort of similar schooling and educational experience, I think too that we all have had different work experiences. We've worked with different populations, different areas of the mental health field. But when we all come together again, we never work a day in our lives because we are meeting people where they are with the passionate and compassionate care that we have. And we want what's best for those that reach out. And Dr. Parker, I really appreciate you coming on to the Better You podcast today and joining us and talking about just such a very, very important topic. And I know you've experienced a lot in your work in the professions field, helping professions field, I should say. And you offer a lot of different services such as individual, group, and couples, and just great, great services that I continue to wish you well working in. And Ravi, I know you had just thanked us, but thank you also for joining us. And we will be returning with another topic for next time. But was there anything that either of you wanted to add before we ended our podcast for today?
Don't be afraid to reach out for help.
Absolutely, absolutely. And there's many different avenues of getting help. I know we went over a lot of different longer term, such as group, inpatient, outpatient resources, but we also talked about that 24/7 988 resource, which you can access. And I'm just letting folks know that are reaching out that, hey, even if you need a safe space to talk or you someone who's experiencing crisis, you can always encourage them to reach out to 988, just dialing 988 on your phone, texting 988, or going onto their website. But until next time, again, thank you both for discussing this great topic with me, and we will see everyone that's been tuning in today very soon.
Thank you.
Thank you.